good morning, afternoon, depending on where you are. I'm Sandhya Venkateshwaran, Senior Fellow at the Center for Social and Economic Progress, also called CSEP for short. And it gives me great pleasure to welcome all of you to this dialogue today. Just a couple of words on CSEP. CSEP is a public policy think tank with research focused on growth finance development, on energy and natural resources, on foreign policy. Very recently, CSEP initiated a work program on human development with a particular focus on health. We are looking at human development both from the point of view of its intrinsic value and also its instrumental value in its contribution to a country's growth. And we're specifically looking at policy for all of the areas that contribute to the development of human capital in a country. And that's where health comes in. And as I said, so we have very specific focus on health. Our work program aims at analyzing health policy and system from the perspective of improved outcomes and reducing the financial risk associated with accessing healthcare. As part of this work, there are several strands to this work, but in the last few months, we have been engaged in distilling insights from health systems across other countries, particularly focusing on mechanisms of governance, of financing, of organization, to see in what way these aspects have contributed to improved outcomes and building resilient health systems. These papers will be on our website very soon, so to look out for them. We focused on 6 countries, that's China, Thailand, Indonesia, Brazil, Turkey, and Mexico. Having done the analytical work, we have now developed a dialogue which basically examines different aspects of health systems. And these dialogues, it's a series, and these dialogues focus on the countries that we studied specifically, but of course they are broader, looking at other countries as well. The dialogue today focuses on the possible pathways to provide universal access, especially in resource-constrained environments. This is a cross-country dialogue, and today we're particularly drawing insights from Thailand, China, Indonesia, and India. To draw these insights, we are honored to have a stellar panel with us, Professor Vinny Yep. We have, Dr. Viroj, there seems to be some confusion. Madhurima will talk about him. He seems to be stuck on a flight. We have Dr. Nachiket Moore and Dr. Jack Langenberger. Each comes with experience in terms of designing or analyzing or different ways of engagement with health systems, and we're thankful to all 4 of them for taking the time out to share their knowledge and their insights with us. So on behalf of CSEP, once again, a warm welcome to all of you, and thank you for joining us. Madhurima, over to you.
Yeah, thank you, Sandhya. I hope everyone can hear me. Okay, so good evening, good afternoon, and good morning. And thank you for joining us for this first dialogue on health systems organized by CSEP. I'll straight away go to the focus of this webinar. So the idea of universal health coverage, better known as UHC, is one of the sustainable development goals as envisaged globally for all individuals to receive health services, which are comprehensive, from preventive, promotive, curative to the rehabilitative services, without suffering financial hardship. It also embodies within it the ideas of equitable, quality, and responsive health services. As Sandhya mentioned, that we at CSEP have been analyzing health systems of select countries and the health system reforms undertaken by these countries to attain UHC in order to draw insights for India. The countries selected are, of course, quite diverse given their political and socioeconomic histories, but there are convergences and divergences across these countries in terms of the dilemmas and the policy experimentations towards UHC, and these really provide valuable insights. So today's discussion focuses on China, Indonesia, Thailand, and India. And we focus on some of the key issues regarding their journey towards universal access to health services. Before I get down to the questions, I would like to introduce the panelists. We could not have had a better lineup of panelists today because getting them together on the same day is quite a difficult feat, but we indeed are lucky to have them together. But disappointingly, Dr. Viroj is unable to join us because he is stuck in a flight. His flight is delayed and he hasn't yet landed. All four are renowned experts in the field of global health systems and health policy and have contributed not just to policy research and teaching generation of students, but also have been architects in designing health systems. Professor Winnie Ip is at the Global Health Policy and Economics in the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health. She serves as the faculty director of the school-wide China Health Partnership and has recently completed her appointment as acting director of the Fairbanks Center for Chinese Studies at Harvard University. Dr. John C. Langenbrunner, better known as Jack, is senior advisor for financing and health insurance. Jack is a health economist and with both research and operations experience. He has worked in India since 2015 and was a senior officer with the Bill and Melinda Gates Foundation from 2015 to 2018. He has also several publications, and his recent book co-author was with Niti Aayog, November 2019, which was on Health System for a New India, Building Blocks. And his other most recent book is Health Financing and Universal Health Coverage in Indonesia. Dr. Nachiket Moore, within India, probably doesn't need introduction, but is a visiting scientist, the Banyan Academy of Leadership in Mental Health, Senior Research Fellow at the Center for Information Technology and Public Policy, IIIT Bangalore, and his current work is principally focused on the design of national and regional health systems. Dr. Viroj, of course, is not here, but he's known as the master carpenter of the Thai healthcare, and it's a real disappointment that he's not able to join us, but we still hope that probably he can make it if his flight lands in the next half an hour or so. So it's a real pleasure to have you all, and thank you so much for agreeing to be here today. The format we are following today is one set of questions followed by a Q&A, and then the second set of questions followed by another round of Q&A. And so we'll get down to the structure now. So we'll have 2 rounds of questions, and each of these will be followed by a Q&A. So we are requesting the participants to please pose your questions in the Q&A box. So let me start with the first question to our panelists. Despite variations across countries and attempts to provide universal access, an important challenge has been of inadequate financing, suboptimal pooling, and there have been mixed sources of financing and pool resources. So general taxation, and there's been a combination of insurance schemes like voluntary and compulsory both, sometimes supplemented by the government subsidies. So in a resource-constrained environment, what are the possible pathways to provide universal access? We recognize that voluntary health insurance is not the path to UHC, since it could pose opportunities as well as risks for equitable progress, but there is a viable possibility of making this an option in a resource-constrained environment. Voluntary insurance as a share of total health insurance is growing in many countries, and one key factor has been, especially in the lower and middle income countries, the emergence of the middle class, which is willing to pay and purchase premiums. So VHI would not mean only commercial insurance, but government managed schemes, or as we see in Indonesia and China. How have China and Indonesia achieved universal access through VHI, voluntary insurance schemes, and what has been the experience, probably since Viroj is not there, Professor Ip and Jack and Nachiket can actually give their inputs on Thailand in this regard. So what has been the experience through these countries, and what are the possibilities, challenges, and future of expanding the voluntary insurance for India? Winnie, can you go first?
Great, thank you very much. It's exciting to be on this panel, and I see a number of friends in the audience as well. So I look forward to interacting with other panelists and also the audience. So your question is, given resource constraint, what role can voluntary insurance play? What is China's experience? What might be the implications for India? First of all, I want to clarify voluntary because China actually has a social health insurance scheme that on paper, it is voluntary. And I will go into that, but I think you are more talking about voluntary in terms of private insurance. Let me start by just saying that we all know that voluntary private insurance cannot reach UHC, and the key reason we have to keep remembering is that private insurance are for-profit. That's the key. For-profit private insurance would only want to enroll healthy people. So let's put that aside, but remember that. I think this question of what role voluntary private insurance can play need to go back to a starting principle. The principle is for a country to think about how much priority it gives to equity. If equity is important, then the government needs to play a big role in financing for healthcare. And I just want to limit to financing for this session, for this question. And so let me just walk through with you what is China's experience and what China does. China makes it very clear equity is important, and therefore the government needs to put in money for financing healthcare. And I have said many times that in a short period of 10 years between 2008 and 2018, China actually quadrupled its spending on healthcare in real dollar terms, in real, not even nominal. And so if equity is important, that is a question that cannot be shy away from. We can't say that a country care about equity, but not put in the money and ask what voluntary insurance can do. So let me just put that straight. And given that still no government can fund everybody and everything, so there still needs to be a question of what to prioritize. But given the equity priority, what China has decided to do in the beginning is shallow coverage, but for everyone. So everybody will be covered, but the benefit package in the beginning is very shallow. And there was a lot of criticism from international experts at that time. But I would say over time, it was the right decision. It was the right decision is because when you have everybody in a same program, over time, when there is money, then everybody get lifted up together. You're not favoring any population against another population. And this has implication on purchasing, which is the second question. I'll come to that later. And so over time, China then was able to put in more money, and the benefit package has been more generous. So actually, recently, China is only until the recent few years beginning to encourage private insurance. And the fundamental question that China raised is that the government should be responsible for basic healthcare, and implicitly saying that non-basic can be left to private. Now, how to draw the line for basic is a much more difficult question, but at least in terms of principle, that's what China is using. So what is non-basic? And at least at this moment, some of the non-basic services are actually things that are rare diseases. So recently, China is actually pushing out a class of private insurance to cover these rare diseases. But these private insurance is rolled out in a very, I think, on the one hand, innovative. On the other hand, it remains to be seen empirically whether it works. The government actually helped promote that. So it's not the private insurance company promote that. The government helped promote them to give people the confidence that these insurance is actually credible. And because they cover rare diseases, it means that a small share of the population would need to spend money on those health conditions. And meanwhile, they're getting almost everyone to enroll in it, which means that the premium that people need to pay is really tiny. So the key is to get a lot of people to pay into that, and the way the government is trying to do it is the government itself is giving people the credibility and the confidence to encourage them to buy it, and therefore you're seeing a lot of programs that say that they would cover a lot if you do have that condition, but you only need to contribute a small amount of money, and this is in a way trying to reduce risk selection. And I think this experience of, so I guess what I'm trying to say is that the road that China has chosen to use is that the government with the social insurance program is responsible to cover a benefit package, what they call basic, but for everyone, leaving room for supplemental for the private. And they haven't defined what is supplementary for the time being. And I think this experience this principle is actually quite similar to a number of European countries. If you look at the Netherlands, the Switzerland, that is, there's a uniform benefit package that is grouped under a public insurance program, and then leaving room for private for the supplemental. But I think all these countries are using the principle of not slicing by population, but slicing by surface. Now, let me talk a little bit about, well, what do these have to do with India? I mean, India has decided by slicing by population already. Now, there's a question of, would the government then still be paying for a public insurance for the missing middle, for the time being, the missing middle, and then still have people buy some private insurance or pay contribution? My view is that there is a role for voluntary insurance, but in the outpatient sector. The problem with voluntary insurance is risk selection. And to reduce risk selection, people need to see the benefit of it. If insurance only covers inpatient, you would definitely only be able to enroll those who are really, really ill. But if you would cover outpatient services, the healthy population would find it valuable and they would find it attractive to buy outpatient insurance. And there, I think that some of the US experience of managed care and also more population-based kind of insurance scheme that get people to buy into a, instead of health insurance, it's almost a health benefit package, but encourage people to have early detection, early screening, early disease management. It is actually not a bad idea for India. But this question still remains, how do you then integrate this with inpatient services, which is covered by the government? So we're not talking about perfection. We're talking about, given your starting point, what might you be able to do? So here are just some of the thoughts that I'll throw out that we can discuss further. None of them is perfect because you still have to start with your starting point. And the starting point is already slicing by population. And then for those that are getting the poorest population, 40%, the focus has been on inpatient, which is again not really the right thing to do, and China really pay a price for it, because when you just focus on inpatient, it actually get the system a lot more expensive, so expensive now that I'm not sure China can continue to pay for that continued increase in health expenditure. I'm just going to stop here so that we can have time for others to chime in, and then we can have a discussion about that.
Thank you so much, Winnie. Jack, can you come in next? Thank you.
Thanks so much, and thanks to the CSEP team. It's been great working with you, and thank you very much for the opportunity to join today. So I'm going to say a few things that are similar to what Winnie has said, and also say a few things that are slightly different. So maybe that'll be a little bit provocative for the audience, and also generate some good questions. So to recount, as Winnie noted, universal health coverage requires pooling of funds, and pooling, of course, allows funds to reach the rich and the poor, the old and the young, the sick and the healthy. But So you can say voluntary public or private managed insurance might be a plus on the one hand. It covers health needs, but it is really not part of the overall pool, which can hurt both efficiency and equity. Now, Winnie emphasized equity, but I would also emphasize efficiency. Efficiency in that the pool is fragmented and purchasing has less leverage. Equity, of course, in that voluntary insurance is often the domain of the upper income and the healthy groups, as Winnie alluded to. And I think the U.S. and South Africa are prime examples here, and we can come back later to discussing some of these country examples. Now, Indonesia, voluntary insurance has not really been a player in reaching UHC. Indonesia began with separate parastatal pools for the poor, the formal private sector, the military, the civil servants, and the police. There are also district-based insurance pools. Indonesia is a very decentralized country with about 520 districts. So there were really over 500 various district pools with different benefit packages, different premiums, and so on. All of these pools, the national pools, the 5 national pools, and the district pools, merged in 2013-14 to form a single payer, and that was quite impressive on its own. Now, voluntary insurance does exist today in Indonesia for private enterprises. They buy insurance for employees, and they buy insurance for families of workers. But it is duplicate coverage. It is duplicate coverage to the single payer, and it does buy greater access to branded drugs, to more tests, to private providers. There's an emergence of big private provider networks in Indonesia, especially in the urban areas. But overall, it is less than 10% of what we would call the insurance market being both public single payer and private insurance market. So for me, from my perspective, if Indonesians were smart, they would consider doing one of two things. The first option might be they could establish carve-outs for these enterprises buying private insurance, whereby enterprises would pay into the single payer, so that enterprises would pay into this overall national pool, but then B, they could receive back a per capita rate, which could be used to establish contracts with preferred providers for their workers. Now, the single payer would both receive these funds and would reallocate them to the organizations, to the employers, but at the same time, the single payer would monitor performance. So these carve-outs would be dependent on performance year after year, and if they don't meet the minimum standards in terms of quality and efficiency, they could be reconsidered. The second option might be to develop a supplemental health insurance market where there would be a very clear demarcation of the basic package and the supplemental package. I think Winnie touched on this a little bit. If you're going to have a supplemental health insurance market, the first principle is really this clear demarcation of the package, what's in the basic package and what's in the supplemental package. And consumers need to know that, whether it's employers buying or whether it's individuals and families, they need to know where the line ends for the basic package and where the line starts for the supplemental package. So any individual or enterprise would pay into the single payer, but then also be free to buy additional services that could be a private room, hotel services, it could be extra tests, it could be expanded drug package, things like that. As Winnie has also mentioned, there are supplemental markets. There are variations in supplemental markets with some good models in the EU. Sometimes they are privately run. Sometimes, as in Croatia and Slovenia, they are actually run by the single payer. You pay an additional 3 or 4 or 5% of the payroll, and you pay into that, and they provide supplemental services. So there's variations across Europe in terms of these private insurance markets. But I think, as Winnie mentioned, the latest data I've seen suggests that no more than 15, say, to 25% of the population will buy this supplemental package in the EU countries. So these two options I mentioned, either a carve-out or a new supplemental health insurance market, they need to be regulated, they need to be monitored, but neither option has occurred as yet. Thinking about India, I think for various political and cultural reasons, and here I'm a little bit different in my opinion than Winnie, but I think that's good. That's good for the discussion coming up. I believe India in 10 years might look more like Germany or Switzerland or Netherlands. Now they have supplemental markets. Yes, they have supplemental private insurance markets, but at the same time, people do have a choice to purchase private insurance, but it would be mandatory, a basic package that would be mandatory, and everyone would need to have some sort of coverage. So you could join the PMJY if you're poor. You could join maybe either a publicly run insurance or privately run insurance markets, but at the same time, it would be mandatory. It's not going to be voluntary. And I want to say that, however, and I'll emphasize that, however, these countries in Europe do manage and regulate these non-governmental insurers, and they do so along certain lines. And I think of it as, at least in 5 areas they manage quite closely these non-governmental or these non-social health insurance markets. First, in the first area, the funds are pooled. The funds are pooled virtually. Perhaps you, as an individual or family or an employer, you pay into one pot, and then it's redistributed to an insurer that's chosen by the individuals or by the employer. But nevertheless, it's a kind of virtual pooling, and then redistributed according to choice. Secondly, the second principle is the benefit package is standard. So no matter which insurer you choose, your benefit package is going to be clear, and it's going to be standard across all payers. There's not going to be any difference. Third principle is that the IT system, the IT infrastructure is standard across payers. So you have some level of interoperability, you have unique identifiers, and you can use that information later to pull in some information about performance and comparisons. Similarly, a fourth principle would be the quality metrics would be standard across all payers for performance assessment and comparison purposes. And fifth, your payment systems would use essentially the same pricing, the same incentive structure. So for example, if you're going to think about a DRG system, as the National Health Authority is now thinking about, that DRG system with the same pricing structure would be applied across all of your payers, all of your insurer organizations, whether you're social health insurance, whether you're a governmental insurer, or whether you're a private insurer. So this approach in these countries are variants of the so-called managed competition model. The managed competition model is really the brainchild of a Stanford professor, Alan Enthoven. It's not a new model. I think he wrote his books in the 1980s, really as a kind of a recipe for the disasters in the United States private health insurance sector. And I think Obamacare in the US did pick up some of its elements, though not all of its elements. I also want to note that the colleagues in India at the Devara Research Institute have been looking at this model, and they've written a couple of very nice papers on its applicability to India. So I'm very pleased that there's some interest already in India about the managed competition model and some of the good things and maybe some of the challenges that the European countries like Germany or Switzerland or the Netherlands are facing. So overall, too, in this managed competition model, the system is governed by a sort of governing board to oversee the system, to update the system. Every year, the benefit package has to be updated. Every year, the prices have to be updated. Every year, the IT system may need some rethinking, the quality metrics. So there has to be a board to oversee performance and also to update on a regular basis. For India, would you have a board at each state? Well, you could, but I would probably prefer to see a national board that would really allow comparisons and best practices to be recognized nationally. And then the last point I'll make before I turn it back to our moderator would be, would India need a new board? And I would argue that no, actually the National Health Authority could grow into this role over time, and say in 10 years, or say even sooner in 2030, this goal could be achieved. And I don't think it's too early to start thinking about a timeline and even thinking about a step-by-step for doing this. Let me stop there. Back over to you.
Thank you so much, Jack. I mean, very interesting insights from Vinny and Jack, both from the Chinese and Indonesian, as well as some of the other countries that Jack mentioned in Europe, regarding coverage, the mechanisms, how insurance works, and the combination of insurance schemes. I mean, voluntary itself is a very broad term in that sense. So it's a mix of, we would also talk about private insurance, but also look at what voluntary means when the government makes a voluntary scheme accessible to people. But of course, the principles of equity and efficiency need to be definitely considered. And I'll move to Nachiket before I kind of make the other points. So Nachiket, please, if you could give your insights. Thank you.
Thank you, Madhurima. I'm happy to be here. And most of the commentary that you've heard from Dr. Yip and Jack is really very valuable and very gives us very important perspectives. I'm going to try to build a little bit from our perspective, the Indian perspective, and see what implications it has. See, unfortunate reality we are facing in India is that the state of public finances in healthcare is in very, very poor shape, and both in terms of adequacy of financing, less than 20-25%. Again, state by state, the number varies, but a relatively small portion of money is coming from tax resources. Schemes like the ESI, which is a social health insurance scheme, which is a relatively large scheme, has a claims ratio of 40-45%. So even the point that Jack made about efficiency, even a private insurance organization has 60-70% claims ratios. And these, many state governments have launched, they call them insurance schemes, but they're really purchasing schemes in which they're using tax money, already limited tax money. They're further fragmenting it, but tiny amounts of it, 0.02%, 0.05% of it. And launching yet another purchasing package, to try and see if they can somehow make that little money that is available spread out even thinner. And while all of the work that you all are doing in CSEP and other people are doing, there's continuing hope that this will change, that the government will give us more money, that there will be ways to use the money better. But I don't see that happening. I in fact worry that somewhere near 70-80% of our population is going to be reliant on the most inequitable source of financing. I know Dr. Yip is concerned voluntary insurance is inequitable, but even more than that is out-of-pocket payment. And I think that is the dominant financing in this country, and in fact, I would argue in most developing countries. So therefore, I don't see an alternative, but for us to really think about what can we do in an environment where the government will remain and public finances will remain a tiny portion of the solution. And we are not talking about supplemental coverage here. We're talking about basic coverage that's just not available to people. Even some of our richer states like Kerala, while it spends a fair amount of money in terms of adequacy, 70% is out of pocket. Now, the question is, I mean, there's no doubt, there's a lot of empirical evidence that you cannot achieve universal health coverage with contributory or voluntary insurance. No country has done it. And even countries that, like the US, etc., that do use insurance markets, a lot of it is mandated, a lot of it is like our ESI. It's really not that people go out and purchase schemes. There is some hope from the marketplaces in the US that you are getting subscription. But if you look at the data post-Obamacare, much of it has been extension of Medicare and Medicare that has brought new people under coverage. It hasn't really been people running out to buy a lot of voluntary insurance. But the question is, in India, we have an even worse position. That even if I want to buy, let's say I'm that unusual individual or unusual family that wishes to buy insurance, I have no choice. There is nothing available in the market. And I do believe that while we will have to wait and see whether that will provide coverage to maybe 25% of the population or 30% of the population, can it at least add some additionality to what is available right now? And there are many barriers in India that I would say prevent that from happening. For example, commercial insurance in India, the entry barrier is 6 times that of the European Union. You need to put up 6 times more capital in India to set up an insurance company than you need to do in France. Right? There is really no logic for something like that. And clearly moving in that direction could be helpful. The dominant form of insurance in India is indemnity insurance. And even the new schemes that have been launched by the governments, by various state governments, have the indemnity character, right? And clearly there are a number of issues with it that I would say we have to learn from Medicaid and Medicare experience, that over a 25, 30-year period, is that really going to end us up in the same position as the US finds itself today, where costs have just ballooned out of control? But there is an opportunity, and the insurance regulator has made some moves now to help us think about managed care as a possible idea. Is it possible that if healthcare providers, particularly the large, well-known healthcare providers, start to offer managed care programs in which primary, secondary, and tertiary is covered as a part of a single package, would that lead to some additionality that would be different from what other countries' experiences? I think there is an opportunity. In any case, I think it's an opportunity for us to move forward on moving from indemnity insurance. And finally, the insurance regulator has announced some time ago a standardized insurance scheme that all insurers are required to offer. Unfortunately, the pricing on that is, in a sense, almost designed for adverse selection, and you haven't seen much take up. Is there a real option for us to think about a public option, an option in which the government designs the program, the government offers it, government administers it, doesn't just facilitate commercial insurance markets from coming in, but brings them all into a program managed by itself, perhaps using a managed care type framework rather than the Israeli style managed care framework, rather than indemnity insurance. Again, I think that would add some additionality. Dr. Yip has been sharing with me some insights. I'd hope she might mention it, maybe it'll come later, about how community-based health insurance, how programs of mutuals and people coming together, there are existing trust-based groups like self-help groups, like credit cooperatives that already trust each other. Is it possible for us to imagine a contributory program from that that then is indeed offers us an opportunity? So while I'm very, very very much in agreement with our learned speakers that really voluntary insurance doesn't offer a pathway forward But in a way, I would say to them, we have a counterfactual. Yes, in the ideal world, the government comes up with the money and then we think about what to do with insurance. We are in a situation today where there is not enough government money and there is a gap, enormous gap. The question is, what additionality can we think about? And that's really where I would like to think about commercial insurance, voluntary insurance. Thank you.
Thank you so much. Yeah, Winnie, you have your hand raised. Yeah. You have to unmute.
I thought it'd be interesting for the panelists to have a little discussion before you take question. Is that all right?
Sure, of course. Please.
Yeah. So I want to respond to both Jack and Nachiket in the following sense. And also, given the audience whom I see the name list, I agree that in an ideal sense is that the government spend more money from both equity and efficiency perspective. But I also agree that we might have to face the reality that if that doesn't happen, what would be the not even second best, maybe third best and fourth best compared to today, right? So I think a lot of time these discussion, the comparison point is not quite the same, right? We're often talking about an option compared to an ideal versus another option compared to the present. I think Nachiket is coming from, and you can go through that employment channel to get employer-employee contribution into the mandatory. And if India doesn't have that condition satisfied, that is formal sector employment, and if the government doesn't put up the money that is needed to have that uniform mandatory benefit package satisfied, then I think we are going down the route of, unfortunately, it's going to be a fragmented financing. So the question is, that's how I would think about it. Among the different forms of fragmented financing, what would be the least damaging? I mean, every time I act on that, in that sense, I mean, Nachiket and I have also had prior conversation. I do agree that there are opportunities, whether it is government run or private run, to try out, and I would like to use the word of piloting, to learn the lessons of some form of managed care. But the key is it has to include outpatient primary care, because that's the only way to reduce adverse selection. That's the only way to try to, and I'm sympathetic to that, is because that actually might also provide some health management rather than disease-based insurance. And so it's not a bad idea to think about it, because that actually also do try to lead to some changes in the delivery system. I mean, we talk about financing. No financing is sustainable until you can change your delivery system. And the only way you can change your delivery system, I believe, is that you have to go through the financing lever, right? I mean, providers, unless the government can directly dictate them, beyond that, it is really the financing lever that can make them change. So I'm sympathetic to that idea and open to that idea, but on a pilot basis, because there are many mistakes that the United States have made. But that was still moving India down a route of fragmentation. But that, unfortunately, and I think the thing we want to think about carefully is how can we do these kind of pilot that would reduce future fragmentation, right? Because we're saying that for the immediate term, it is very difficult to see the government putting up more money. But at least we don't want to test out managed care in a way that create a situation that at the time when the government are able and willing to put in money, it is not possible anymore. I don't know how I'm saying it, but you know what I mean. And in the rural area, it's some form of risk pooling scheme that draws on the self-help group and all of that, and we can talk about it separately. So I think that for the conversation today, there's a question of I think the big elephant in the room is the government going to put up more money? And that's going to be two very different options that we're proposing.
Thank you, Winnie. Yeah, Jack, please go ahead.
Thanks very much. A couple of comments to follow up on Winnie's many good comments, and I can't answer them all, but I do agree with this issue of fragmentation. And a scholar at the World Bank, a scholar from Assam state, once said to me, the problem with India is that they have reform after reform, but they put each reform on top of the other, and they never quite rationalize the entire system. So the fragmentation issue certainly rings true. Now, I also like her ideas about piloting, and, you know, going back to my point about having a board could oversee the piloting. The board could oversee the piloting, and in China, they have pilots that ongo all the time. In the United States, we have at any one time over 200 pilots in the Medicare and Medicaid program alone. Some of these are county-based, some of these are state-based, some of these go beyond the state level, but nevertheless, you know, the federal government says, who has an idea? Please come to us with an idea, or maybe the federal government has an idea. The federal government puts some money into it. There is a design period. There's also an evaluation that is mandatory. There must be an evaluation. And there are only two criteria that you really need to address when you develop a pilot. One is cost containment. Is it going to cost the same or less than the way we do things now? And quality. Will outcomes change? If the outcomes are going to not improve, then you may not meet the threshold for putting together a pilot. These pilots run for 3 to 5 years typically. One of the interesting things about pilots is that some of them may not be so successful from a technical standpoint, but people like them. People like them. People say, let's do it this way in the future. And so they are integrated into legislation. In other cases, you see just the opposite. They may be saving money. One pilot recently was a coronary bypass surgery where they paid for an entire episode, but they also had centers of excellence in only a few places in the country. Let's say Texas, and let's say Boston. Let's say Los Angeles. People didn't want to travel. They didn't want to travel, so they didn't really like that idea. So anyway, these pilots could be done, and they could be done through the National Health Authority, and that would be quite interesting. Now, the public option and the issues of I like the public option idea. I also would say let's think about it in terms of the Chinese experience, which is in the rural health insurance program. It was voluntary, but at the same time, the Chinese government put up, I think it was something like, well, it was a combination of national and state level and local level funding, but altogether it was something like 90% of the premium. And there were also targets. There were also targets in each county that leaders needed to reach in terms of the center, the national level being happy. So, you know, county leaders told me they would go door to door. They would knock on the door. They would enroll people. If they couldn't pay their premiums initially, they covered that 10%. That wasn't a problem. And so they were able to enroll a very large number of people in this rural health insurance scheme. I'm a little out of date on what happened. I'm sure Winnie can correct me, but I do think, coming back to this public option, there could be some public option. It would have to be subsidized. But there is money in the system now. The money in the system now is going to line items. Money is going to line items. It's going to supply side funding. What if you reallocated that money into pools that would subsidize premiums for the public option, or say for another option that people could choose? And that's where I think the politics create a huge barrier in India. But nevertheless, I think the NITI book in 2019 laid out step by step on how this could be done, on how the line items could be diverted into more of a pooling mechanism. The pooling mechanism could in turn then subsidize the premium. So I think this public option is quite interesting. There could be some adverse selection. People might choose a private option, but then get very sick and have to move to the public option where they would be very expensive. So I do think there could be some adverse selection issues, but nevertheless, interesting idea that's put on the table. Back over to you.
Thank you. So given in the interest of time, I'll just take up one question probably from this particular discussion that we had. So there's a question on, given the evidences and experience, a supplemental role for the private health insurance is apparent. The continued exclusion of primary care from all types of insurance or negligible progress on it is worrisome. Professor Vinny touched upon it, of course, but in reality, government and insurers alike are risk averse to cover outpatient services. Government coverage of primary care is in the form of health and wellness centers, as we see in India, but continuum of care is missing. So private insurers' outpatient services is poorly underwritten that costs a large fraction of the coverage benefit as the premium. So how do we see UHC progressing in this kind of an environment? Nachiket, would you want to go?
See, I think there's a little bit of subtlety that I want to point to, and maybe Jack and Dr. Yip can comment on it. In an indemnity insurance environment, which is where we are today, primary care is not insurable. It doesn't have the volatility that is needed. So if you're going to deduct 30-40% of the cost from that to take care of your administrative and channel costs, it's just unworkable, which is why in an indemnity market, one would talk about prepayment, one would talk about subscriptions, one would talk about other mechanisms that one could explore. I think in a managed care environment, where you're now talking about a program in which healthcare is a part of the overall, there, I think what Dr. Yip said is a very valuable point, that if you don't actually have primary care as a part of that overall structure, then what are you managing? The whole idea of managed care is that you're managing for early impact, you're managing for long-term impact, and you're not simply waiting for people to show up with advanced cancers and advanced cardiovascular situations. So that's, I would say, the subtlety. If the question is, why don't we add out-of-pocket insurance in the current indemnity environment? I just don't think that's an interesting idea, because it's not consistent with the nature. I would go much more with what Dr. Yip said earlier, which to me has been an important kind of defining issue, a shallow universal coverage, for tertiary care, rare diseases, rare conditions, that meets the character, because now you've got very high volatility, and the volatility reduction that you get through the insurance function allows you to pay for a large expense. So I would go much more, in fact, almost in the opposite direction than in the direction of out-of-pocket payments for primary care in an indemnity environment.
Thank you, Nachiket. Vinny, do you have any comments?
No, I agree. I mean, when we talk about outpatient, it's not really like isolated outpatient services. It's really taking an advantage that there is a gap to try to introduce some new ideas to really try to get people to enroll into health plans to make them happy. I mean, to use the China experience, now that only has happened in the, I would say, richer and middle income cities. There are experience of these insurance plans selling, they don't even call it health insurance, they call it health benefit, okay? And it's very attractive because they tell people now when you have problem, you can always come to this clinic, you don't need to go around, we can guarantee you that the drug we provide you is not fake drugs, and they send out reminders that you have to come and do your health checkup every year, and they enroll the parents, the children, and the thing that they use to attract people is, one is this prevention program, but it's also it's nice service, right? You go into their clinic, it's clean, it's orderly, and then when you have that group, once you have an engaged population, you can also do other things in terms of provider payment as well to change the behavior of the provider. And so that's relevant for the next question that you're going to ask, because financing cannot be talked about in isolation with the service provision, and the linkage is provider payment and purchasing. For as long as you do not have a captured population, the kind of provider payment that you can use creatively that is really encouraging people to keep themselves happy, healthy, is very limited.
Thank you. Jack, any views? Very brief.
I don't think so. I think you can either have managed organizations, and you could do that through pilots, or you could do that through aspiring employer organizations that might be interested to do that, as we saw in California and the USA 100 years ago. Or you can manage the market. You could manage the market so that over time you have to really start extending that benefit package and make it mandatory. Over to you.
Thank you. Thank you so much. Let me just quickly move on to the next question, because we don't have much time left. Then we can come back to the questions and the discussion. So we have already, in a sense, addressed the second question also in many ways, but then this is more specific to do with strategic purchasing. Once the money is pooled, then how does one spend the money to get more health for the given money? So strategic purchasing has been viewed as one of the key policy instruments to achieve the UHC. Many countries are moving towards this direction. So as we see in the case of Thailand, China, and Indonesia, the purchasers are typically public agencies who detail the core purchasing functions. They specify the benefits, contract arrangements, and provider payment and performance monitoring is being done by them. And they have set up institutional mechanisms for these. So like Indonesia has a Social Security Managing Agency, BPJS, to implement their national health insurance. Thailand has the National Health Security Office to implement their universal coverage service. And China has recently institutionalized tried to institutionalize the fragmented system that they have under the NHSA, which is the National Health Security Agency for purchasing services for implementing their rural and urban health insurance schemes. So what have been the experience of these agencies in purchasing comprehensive services? Also the challenges in terms of the power dynamics between the Ministry of Health and these agencies. So can Jack has already alluded to it, but can the NHA, the National Health Authority in India, be seen as playing a similar role in India? And so can we get some insights? Also, it would be good if some of you just allude to what experiences Thailand has gone through. Thank you. I think, Jack, would you want to come up first for this?
Thank you very much. I know a little bit about Thailand. I will extend the discussion, and your point about governance is extremely important. And I think this has been a challenge in Indonesia, and I will sort of touch on it through the strategic purchasing discussion. And first of all, let me say I'm an enthusiast for the National Health Authority of India. They're off to a good start. They've had good leadership. They've had good experts. And while it's a long journey in most countries, They have done some encouraging things. Now, Indonesia, yes, they have merged funds, as I mentioned earlier, and they provide a single payer, currently covering about 82% of the population. They've had great aspirations to be a strategic purchaser, and they've developed some good payment mechanisms. And as you mentioned in your introduction, we really, when we're talking about this strategic purchasing, we really look at the literature from, say, the EU Observatory or the World Bank or other places, and we see strategic purchasing is really embracing 4 or 5 main functions, or what I call levers for efficiency and quality. One is the coverage, or, the shorthand might be the who. The second is the benefit package. Shorthand might be the what. The third lever might be contracting, the from whom, the shorthand. The fourth lever might be payment, how much and at what price. And the fifth lever, and a very important lever, is accountability, or the quality assurance mechanisms, to how well the purchaser and the payment models and the contracting is actually performing. So with coverage, very quickly, just a minute or two on each of these functional areas. On coverage, I've mentioned they now pool 82% of the population. However, public funding is fragmented, with over half going to fiscal transfers. The fiscal transfers are really tied in some way, but there's no reporting back. So it's really and they often have different rules and regulations through these fiscal transfers. So the purchaser, the single payer, only holds about half of total public expenditures, and the leverage is diminished in this regard. This is probably lesson number 1 for the National Health Authority, right? And it comes as no surprise that pooling and leverage to purchase strategically is needed, and they are only now pooling a small fraction of the funds. So this would be sort of lesson number 1 I would put on the table for the National Health Authority. Second lever, the benefits package. Indonesians did a good job when they developed the benefit package. They had a positive list and a negative list. The PHC package, the primary healthcare package, was initially 355 discrete items, and they put together provider teams. I was quite impressed in putting together this list. The not so good part was that the services came first, and then they wanted the money to deliver it. And I would say lesson number 2 for the NHA, I would recommend the other way around. Start with the money, and then find the package of the most cost-effective services. Because of the way they did it in Indonesia, services first, the package was too big, and then out-of-pocket payments kicked in at the back, and providers sometimes use out-of-pocket payments to improve their revenues. Third area, contracting. I would say there's been some relative success in Indonesia. They've brought together public and private providers, and over 50% of all utilization is now in the private sector. People had a choice to pick their primary healthcare doctor or clinic in the beginning, and then clinics could then refer, although there was some patient choice in that referral as well. There still are issues. Supply side readiness is not always there in the private sector, so that the supplies, providers, equipment are better in the public sector, but people prefer the private sector for the usual reasons. I'm glad Winnie mentioned it, but for the usual reasons of sort of clean environments, provider attitude, and absence of queues. Still, I would say the public sector is going to be absolutely essential in rural and underserved areas and for years to come. I don't think the private sector is going to spring up in these underserved areas. Could be wrong, but that would be my guess based on the first 7 or 8 years of experience. The fourth lever, payment, here I would say they implemented sophisticated models to begin with, but implementation itself has been less than successful. One reason was IT. It wasn't fully developed in implementation, though it has advanced over time. And they do have now unique identifiers for every person and every provider. They did have a data dictionary, but the data dictionary wasn't always complied with. So there were some good things and some not so good things there. On the primary care side, they implemented simple capitation, but it wasn't adjusted for severity of the enrolled group. Typically, you want to adjust for age and gender. Second, there was no inflation updates, and that there has been no inflation updates for the last 7 years. They're only now sort of thinking about it. And of course, that's had a negative impact. Third, they haven't been fair to the private sector in terms of adjustment for capital or supply side readiness, as I've mentioned above. And fourth and last, I would say gatekeeping was more or less non-existent, and that spilled over into hospital problems. On the hospital side, they did insert a DRG system, but they used an old US software system from, I think, 2010 that reflected US protocols and US cost structures. Price did not match cost, as you might imagine. Big surprise there. They are now, after 7 years, adapting the Thai grouper. The Thai grouper is an offshoot of the Australian grouper, and inserting their own cost structures. And so we do see progress today, and I'm very pleased to report on that. Here, I would say with the National Health Authority, they are moving to DRGs from their package payments, but I think very carefully. And they are quickly learning best practices from many countries. And so I've been very, very happy with what I've been seeing and hearing in terms of their step-by-step in terms of moving to a DRG-based system. Final function, accountability or quality assurance mechanisms, and this is really the saddest part from Indonesia, from the Indonesia story, in that there has been little or no effort to monitor quality and performance, only to pay claims. As a result, there's been gaming, such as upcoding. There's been rather significant upcoding. There's been unnecessary admissions. So there was one study that found 16% unnecessary admissions in Surabaya, a major city in the Java island. But probably my guess would be that 16% is a sort of a undervalue of what's going on nationally. I would probably put that number at least 20%, maybe higher in terms of unnecessary admissions. So, and we see that overall expenditures for primary healthcare as a share for overall spending has gone down since the beginning of the single payer. And we think it should be the other way around. It was a single payer reform that was intended to really center around primary healthcare, but it's done just the reverse. And I think this is in part the outcome of some poor payment system implementation. So coming back to some final thoughts, I think for the National Health Authority, looking at some of the webinars I've been attending, I think the accountability measures have been there and there from the beginning. I think different states are really trying different things. I might be a little out of date, but again, I think there has been some initiative to have accountability measures built in. And often the RSBY experience was very helpful, I think, in having the PMJY payers think about accountability measures. So final thoughts for India, final thoughts for National Health Authority, as we've talked about, they really need to move to some sort of primary healthcare benefit package. I think they initially need to develop a positive list, not just take what's available at the health and wellness centers, but really developing a positive list and then saying to providers, both public and private, here's our package. Here's our package and who's interested to contract with us. And this is how much we're going to pay. So I think by doing that, and there may be a couple of iterations, there may be a couple of rounds, I think they can move to more of a unified package, including both primary and secondary care. And the second is pooling of funds. Again, they really need, I've said this before, but they really need the current line items going to public facilities and states to instead begin flowing to the National Health Authority. And I think once funds are more fully pooled and the primary healthcare package is developed, I think the mission and the real possibilities for the National Health Authority can be achieved. Now, Thailand they moved this supply side line item budget to the insurer, to the purchaser, and they did it overnight from December 31. And at midnight, it all went to the NHSO. Now, how did they do it? Well, they did it in a soft way in the sense that they kept their line items for people in public facilities. So you have your providers, your doctors and nurses, they maintain their salaries. And if you look at the budget of any hospital, public or private, 60 to 70% of the payment would be salaries, right? So the trick was they moved that money and they did a sort of no harm to providers by continuing that level of salaries and the same number of people. Over time, they autonomized some of their public institutions so that there was more flexibility in terms of hiring and firing. But then the rest of the money, let's say 30% of the action, was really put into a performance-based DRG system. And so it was a bit of a compromise. It was a bit of a soft reallocation of funds, but nevertheless they did it. I'm sorry that Dr. Viroj isn't here today, but maybe you can bring him on at a later time. And let me stop there.
Thank you so much. That was really insightful. Vinny, can you go next? Yeah.
Yes, in the interest of time, I'm going to focus on some big picture. So one, you're correct that China established the National Health Security Administration a few years ago, NHSA. One reason China established that was because previously the rural insurance scheme is run by and managed by the Ministry of Health. The urban scheme is managed by the Human Resource and Social Security, Labor Security. And so in order to combine those, it's just politics. The government was not able to get the Ministry of Health to agree to give up rural or the labor to give up the urban. So they set up a new administration and combine them together. But it's not a bad thing. But because of setting up this new organization, agency, it is possible to then integrate previously two separate programs into one. And I think that's important. Let me talk about a few things. It is a government department. This is the biggest difference between China and Thailand. Thailand's NHSO is a public organization outside the government. So it creates very different governance structure. Within China, because it is a government department, it is held accountable to a vice premier in the state council directly, rather than to a board that with people representing them and all of that. So it's a very different accountability system. It's government run. So far, what is the experience? So far, one of its greatest achievement is that it was able to launch a very effective bulk purchasing policy and program for drug. And the prices for the drugs for the basic services that are covered by the program, some of them have gone down by several hundred times. And just think about how much money is saved for the insurance program and for the people. The second category is bulk purchasing of equipment. Again, the price had just come down huge. And when you have a centralized purchaser who covers 90% of the population, I'm sorry, the supplier do need to pay some attention to it. So this is really exercising market power in a very effective way. And what it has not been able to do effectively is that I think the focus is too much on controlling health expenditure and not enough attention on what it is buying for people. So, I mean, we actually run a number of training courses for them on value-based purchasing. But if you think about people's mind, from their perspective, value-based purchasing is cutting costs. And we keep telling them that value-based purchasing also means increasing quality. And that just hasn't gotten into their brain mindset. And that get me to my favorite point recently is about corporate culture. Because this group is started, the NHS is staffed by a number of people who used to be managing social security, public security, rather than health. Their perspective, they come with a culture and a priority of managing budget. And the idea that this is about health, you also need to be trading off about quality and really value for people. They talk about it, but it's just not in their head, and therefore it's not in their action, it's not in their decision. And the next challenge that I see is that you set up this new organization like India. China is huge. Every province, every city has a parallel of that office. And the people that they can recruit to do the work that is required to design benefit package, to design payment method, to implement it, and all of that is so thin, so thin. So it is really a large group of non-experts managing this big organization in a decentralized way. I take my hat off to China to be able to build this up very quickly, but because I do a lot of training for both the national and the local office, I know the capacity is very thin. So my one advice is that I know NHA is doing quite well in India, but it is important to strengthen its capacity to do things and design things well. It is not easy. And rather than being ambitious, do things gradually, but do it well, rather than adopting a name. And this is the problem with China. China said it's going to roll out DLG. The DLGs that it is rolling out is not done correctly. It's not estimated correctly. So in name, it has done things, but in practice, it is not done the right thing. Thailand, I think that the major lessons one should learn from Thailand is take that organization outside the government, make it a public organization that has a board that holds it accountable. And the board is made up of people from Ministry of Health. So health, the delivery side, because once you have this separation of purchasing and delivery, Ministry of Health become much more focused on really just the delivery side. And if they are at loggerhead, which is China's problem, you can't even invite Ministry of Health and the NHSA to come to the same conference. You have to be able to have a board or some mechanism for the delivery side and the payer side to come sit together and make them feel that they're at the table to be able to negotiate. Otherwise, you're going to get the two sides to not talk. I don't see any health system that can produce any good thing when the delivery side and the payer side really hate each other. And so Thailand does that. And because by taking away from the government, it is also able to allow it to have flexibility that is not tied by rigid government rules that usually subject to much more bureaucracy. And I see in Thailand also much more proactive in, they have a separate board for quality. They have a separate board and group that accreditate providers before they would purchase from them. And I think all those are important to learn. And I think China is falling short in terms of those things. It says on paper that it's doing selective contracting. I just haven't seen any provider that is not being contracted. And if any provider is having fraud, I just haven't seen their contract being discontinued. So you do need to have a little bit of a distance to exercise those power. But I think if you talk to the Thais, they would tell you that, yes, despite their effort to try to have Ministry of Health to have a say in the decision of NHA, the relationship between them and Ministry of Health is still difficult. They would say that they're in a yo-yo situation. Sometimes they're better, sometimes they are worse, but I think that's just the reality. And I would not, those are the things I want to say.
Thank you. Jack, can I come back to you later, probably after Nachiket has responded? Yeah.
Yes.
Nachiket, please go ahead. Thank you.
I'm happy to. We are almost out of time, right? We close at 7:30. Do you, Madhurima, you're on mute.
Sorry, we can extend a bit. That's okay.
Okay.
Yeah.
Well, I'm happy to. So, you know, this has been a wonderful conversation. And really, as Jack said, I think the work that he did for the Niti book really laid out a pathway for strategic purchasing. And strategic purchasing, you know, one way to think about it is the way the NHSO, the dramatic move forward. But I think the point Jack has been making for a while is that even reducing the number of line items could actually have a beneficial impact, even if we don't actually end up with this big bang, which I don't see happening in India. And what is the value of it for India? I just want to put out a hypothesis that you know, I am researching for a commission that I'm a member of. So one of the you know, kind of ratios that we talk about when we say is India spending enough money on health or not is the national expenditure on healthcare divided by the GDP. And then we extend that to the state level, and then we say we should look at the state expenditure divided that by the state GDP. I'm in one of the papers we are going to argue that that's a fundamental error, because the reality is that the cost structures are not that different between states. A nurse costs the same because of the slack labor market and because of free movement of people in a richer state as she does in a poorer state. Which means you should look at state expenditures as a proportion of national GDP. It turns out that many states have crossed 2%, 2.5%, 3% of national GDP as far as health expenditure is concerned. And of course, it also means states like Bihar, who look like they're doing better because they're doing 1.4% of their GDP, actually turns out to be 0.4% of national GDP because actually they are not a very rich state. I think that presents a more accurate picture of the reality on the ground, which then means that many states, you know, and we hypothesize that there are at least 7 states in India that today are spending enough money to offer universal healthcare to their people. Why are they not able to offer it? Because we think, or we are going to argue, if we get to this point, that there is massive inefficiency in expenditure, massive inefficiency in expenditure. There is huge overutilization of secondary and tertiary care. If you look at C-section rates in some of these states, they have crossed 40, 50, 60%. And in some states, the government does more C-sections than the private sector, at least in some districts. And primary care, even if it's well-equipped, there are states which do have well-equipped primary care, is basically empty. 1 patient a week, 1 patient a month, you know, really not being utilized at all. Is it possible that a strategic purchasing type mechanism that either goes via the state health authority with all of the caveats Dr. Yip had about local capacity, or some other mechanism really unlocks this value so that you're able to see gatekeeping implemented, you're able to see good electronics that moves back and forth. Currently, there's no incentive. You go to these governments with training programs, with ideas, so long as the donor is willing to pay for it, they're happy to do it. But the minute you say, no, you have to pay for it because you should see value in it, the interest level just drops like a stone. So to me, that's kind of, to me, the appeal of where a strategic purchasing could have a value, not necessarily across the country for all states, but in the spirit of piloting, maybe not at a district level, but maybe at a state level, particularly the more high capacity states in the south or the smaller states in the northeast, all of whom seem to be spending more than enough money on healthcare. Is that something that, you know, could be explored as an idea now that we do have the NHA and the SHA, and use that as a tool to do it? So I'll stop here. Thank you.
Thank you. Jack, you wanted to say something earlier?
I wanted to come back on the governance points that Winnie made, and I didn't quite talk enough about Indonesia. So there is a governance challenge in Indonesia. The purchaser, the single payer, the BPJS, reports to the president. Unfortunately, the president doesn't have time to really manage the single payer organization. But there's no direct linkage with the Ministry of Health. So the Ministry of Health and the single payer have sort of competed more than collaborated over these 7 years. And that's been a real challenge. So, you know, the benefit package, well, they fight over that. The payment, well, they fight over that. And I think that this is a good lesson. The other thing is that they have a board at the single payer, but the board is under the CEO. That's just the opposite of what you want. You want a board that is over the CEO, that can help the CEO and the organization. So they have a board that is strictly sort of, well, here's an idea, but really not having any kind of weight, any kind of impact. So I think these are good lessons for other countries. I like Winnie's idea about somehow, you know, in Philippines, if you go to PhilHealth, they report to the president, but at the same time, the Minister of Health is, the Minister of Health of the Department of Health is the board chairman of that board of PhilHealth. So I think that those kind of things are very, very important to integrate these two organizations. And I've seen fighting not just in Indonesia, but in many countries. I've seen it in Russia, and I've seen it in quite a few Eastern European countries. And this is wasted time and wasted money, and wasted quality for consumers. Over back to you.
Thank you. Yeah, Winnie, you have a response.
Yeah, I think on this point that it's not a small point about the relationship. The more powerful NHA grow to become a purchaser, the more likely it's going to be become hostile with the MOH, because the MOH see it as something to try to control that. And actually, if you look at a number of the European, but also let me give you an example of Taiwan. When Taiwan set up its national health insurance, there is a board, and that board actually is responsible for deciding on benefit package, deciding on provider payment, and based on what is the total budget that they have. And it has a really combination of Ministry of Health people and employer who pays into it. In other words, different, and finance. In other words, there is equal representation of the payer and the delivery side, and also the patient as well. And also they have a few academics. What is the job of the academics? The academics' job is there to be mediator and arbitrator, because they are neutral. And in a way, this idea of taking it away from the government, I know it's a very big change, but I do admire Thailand doing that. I mean, I'm speaking on Vero's behalf, is you do take it away from some of the standard government bureaucracy and rules and things that you subject to the agency too, which China is not able to do that. It's still part of a government agency, and you're still subject to hiring rules, you're still subject from purchasing rules and all of that. So in other words, there are countries besides, there are systems besides Thailand that have important and interesting lessons to learn from, short of having to take it away from the government.
Thank you so much, Winnie. Okay, Nachiket Yaku.
Yeah, just a quick question to Dr. Yip and maybe Jack. I mean, I see the point about the two collaborating, but in some ways, if the Ministry of Health defines itself as a provider, unless we have also got some other mechanism that in some ways the purchaser is accountable to the consumer and not to the provider, so that we don't have the prioritization of the health of the public sector over the health of the public. Maybe the tension is good. Maybe the tension is inevitable and actually desirable. Because I don't think a ministry can say, I want to be a policy-making body and a provider, But I want to have control over payment.
Yeah, so Nachiket, I think that theoretically is true. But I think by now we have observed in many countries that in practice, Ministry of Health, instead of saying that you and I can hold each other accountable, we've seen many situations that Ministry of Health decide to say that if the terms are not what I like, I'm just going to block you. You do want to have some mechanism that they can negotiate before it go out and become a policy and they try to block each other. Jack.
Quick story. I was in a meeting with the Minister of Health many years ago in Indonesia. They found that there was corruption in terms of how they sent in claims for their patients in public hospitals, a couple of big hospitals in Jakarta. The minister said, oh, you know, we have to protect our public facilities. And the CEO is a friend of mine, let's just drop it. So, you know, you do, tension is okay, but a little bit of tension is okay, but it has to be less than competition and unwillingness to work equally with each other. Over.
Okay, I'll just quickly take two of the audience questions. One is, of course, directed to Jack from Dr. Ajay Tandon. So he says that Indonesia's BPJS is a bill-paying agency and not a strategic purchaser, almost like a TPA. They don't determine the benefits package or the tariffs, so there remains confusion as to exactly the importance of their role in improving effective service coverage and financial risk protection, especially given that a lot of financing to public providers still comes via line item budgets from district governments and not via the BPJS. So has their role expanded recently to become more of a strategic purchaser and being able to determine and negotiate prices and improve quality?
Well, he or she is exactly right. Okay, they are more of a claims processor and less of a strategic purchaser. Now, this has not gone unnoticed by the payer. They know that they are still a claims processor and not a strategic purchaser. And there are, over the last several months, a new minister from the private sector who's not wedded to the public sector, the Ministry of Health. He's gone about first reorganizing the Ministry of Health and secondly saying, let's start rethinking about who does what. And so it's a slow process, a painful process, but you know, with the benefit package, we see some incremental movement with you know, things like actuarial analysis of new benefits. These have to come from the single payer. Things like new technologies, how much are they going to cost? Things like, are new technologies being, even if they're in the package, are they being appropriately used? Only the single payer has the claims. They need to do the monitoring and surveillance. So some of these things need to shift back to a more equal relationship. But yes, that work is still ongoing, and I hope that at the next webinar we will have better things to say. But exactly right on the money. Over.
Thanks. I mean, there's another question. I mean, probably each one can answer very briefly. That primary care is critical, is core in LMICs in lower middle income countries. And health per capita is key. And therefore, I mean, in the sense, like we have seen how systems have worked during the COVID-19 events and how systems have failed world over. Can we learn from technology, e-governance systems in primary health? And what kind of transparency and last mile connectivity can be considered while providing primary care? Vinny, can you go first?
Maybe Nachiket would be a good person to answer this one.
Sure, Nachiket can.
No, happy to quickly comment. I know we are out of time. Now, clearly technology can play a role, no question. Clearly primary care has not worked as well. But, you know, there are no panaceas here. You can't say that everything is broken, let's just add some technology and e-government, and then, we get a smooth solution. Ultimately, the discussion you've seen so far has spoken quite a bit about the power of financing. I would urge you to take a look at research by, say, Jishnu Das, who does these very careful randomized controlled trials to show you that under a line item system, the apparently highly trained is in fact the worst provider of the healthcare. But that doesn't mean sometimes RCTs can conclude too quickly, therefore that the market works. That doesn't necessarily mean that, but what it does tell you, incentives matter a lot. And sometimes if you have incentives that are poor, adding technology can make it even worse. Because now you can, as you've seen in telemedicine in India, earlier you were forced to go to the same doctor, not because you were loyal to him or her, but because no choice. It was your neighbor and you had to go there. And that perhaps gave you better primary care than today in an environment. You can dial somebody and, I talk to somebody in Lucknow and then I talk to somebody in Delhi. Am I really getting good primary care? Even though I've got great technology now. So yeah, I mean, technology, I think, can have an important impact, but I would hesitate to promote that as the panacea.
Yes, Jack.
I would say two things quickly. One is that going to many webinars, of course, I had nothing else to do during COVID, so I went to many webinars and I was impressed with how many innovations were coming out of India. And these were often upstarts, small companies, individuals. In the US, we like to talk about Steve Jobs working in his garage. Well, I think these were innovators in India that really had ideas and really started, they were really starting to develop them based on the COVID necessities. And so I was impressed, but how appropriate they are going forward, that's another issue. And I think Nachiket has touched on that. The last comment I'll make is the G20 discussions are moving to India next year. Use the opportunity to learn from primary care. Focus on primary care. This year in Indonesia, there was a lot of focus on resilient health systems. Very interesting, but at the same time, use the G20 forum. Get many of the voices and thinkers from the G20 countries to weigh in on primary care and how it might help India. Over.
Winnie, any last words?
I think we had a very rich discussion today, but many of them really can be taken into a bit more depth. Because obviously what can be done in India, international lessons are important. What can be done in India depends very much on two things. What is India's starting point? Because that really would have constrained us on where we go next. So we can get to practical solutions. Two is also, I do think that India has a lot of innovation if given time and the right environment. So the idea of whether you call it piloting, demonstration, I know the word pilot, people don't like it sometimes, but the idea of really creating the right environment for these new ideas to be tested out, because India is complex, to be tested out and then draw lessons, but also build in some mechanism for scaling. That would be a very important process moving forward. I just want to say that every one of us wants the government to put up more money. That would be the best way. But I think we are also confronted with the reality that in India, in many other countries, it's not going to happen, especially after COVID, especially these few years. I think we are back in a situation, I mean, even China, I mean, when I told you they increased 4 times of their spending, that was when their economy is like growing very well, but that's going to be a different situation. I mean, the Ministry of Finance has told everyone in health that no more new money. I mean, the best is to continue status quo, even that is hard. Unfortunately, we're in a different place. And I think something that we haven't talked about is, I think now there's a lot of political attention and movement to try to maybe put some money in COVID related or pandemic control-related initiative. And I think this question of where the health system and the public health system should really intermix, where they cross and not cross, is a major question. Is it really distracting, driving resource from the, is the pandemic public health system drawing resource from the healthcare system, or is it a good opportunity to try to leverage the two of them to a better situation? I worry that the current conversation around the world is going to fragment it even further, and that would be unfortunate. I mean, we didn't cover it today, but I think it is important to bear that in mind.
Thank you so much. This was a really valuable, insightful discussion that we had today. I'll just say that each of these, I mean, we kind of understand the complexities of all health systems through these discussions, and hope we have more dialogues on specific issues in the future. I mean, one, of course, is there on the 25th of August, which is on strengthening primary health care, and we hope all of you will join there. And I mean, each of these also can be conferences in itself, each issue, each topic that we take up. So we hope to have more dialogues with all of you. And I really thank the esteemed speakers today for giving us their time, insights, analysis on the health systems, on the global health systems of countries under discussion. Indeed, there is a lot to learn from one another, and we hope to continue this conversation and organize further dialogues. Thank you so much. Thank you.